Hi, my name is Matt Rettig. I'm a professor of medicine and urology and the medical director of the prostate cancer program at the David Geffen School of Medicine at UCLA. There are two important settings where novel imaging may be critical in the initial staging. First, patients with high-risk prostate cancer. So, for example, a high clinical stage T3A or greater, very high serum PSA, as well as high Gleason scores 8 and higher. So these high-risk patients may have occult disease that is not detectable on conventional imaging. And that's very often the case. So one setting where I tend to use novel imaging modalities, especially some of the new PET imaging probes, is in that space, trying to identify occult metastatic disease that cannot be detected on conventional imaging. So for example, if we use one of the novel metabolic PET tracers, such as C11 choline or C11 acetate, there's a greater likelihood to detect metastatic disease, although the specificity of these imaging modalities is somewhat low. So it can we can get misguided when we see a metastatic lesion on one of these newer PET images, and it may not represent metastatic disease. So it's important to understand the biology of prostate cancer, the patterns of metastasis, so that one can make an informed decision about the relevance of some of these imaging modalities. Now, more recently, the PSMA PET-CT scan has been studied quite a bit. And recently, actually, it got FDA approval, but for only 2 sites in the country, UCLA and UC San Francisco, which were the 2 sites that submitted the new application to the FDA. And in the initial staging setting, the PSMA PET-CT scan can upstage patients in about 30 to 50% of the cases. And the overall performance of the PSMA PET-CT is better than some of the other metabolic imaging PET scanners that we talked about, whether it's C11 acetate or C11 choline, or even FDG PET, which is generally not a very sensitive tool for most prostate cancers. So the PSMA PET scan, if it's available, is something that we use, and it often changes therapy for patients who have metastatic disease detected on the PSMA scan. And this can result in either the avoidance of local therapy if metastatic disease is detected, or occasionally when there's oligometastatic disease, we take a sort of a multimodal approach where radiation to the primary tumor is done, as that's been shown to improve survival in patients with oligometastatic prostate cancer. And we also consider metastasis-directed therapy, typically radiation, often in the forms of stereotactic body radiation therapy, SBRT. Although the precise role of metastasis-directed therapy in patients with metastatic castration-sensitive disease, especially those patients who are presenting with metastatic disease, is not well established. So I think that whenever possible, especially in patients with high-risk disease, I like to do a novel imaging modality as part of the staging. If it's a patient with metastatic disease that's been detected on conventional imaging, there are 2 scenarios. Well, there's one scenario where I will use it and one scenario where I will not use novel imaging. So if the patient has polymetastatic disease on conventional imaging, there's really no point in doing additional PET imaging because it's not going to change what we do. Conversely, if the patient has oligometastatic disease, and we're going to take an aggressive approach with a combination of systemic therapy, local therapy to the primary, as well as potentially metastasis-directed therapy, I'll want to know as much as possible about the status of the metastatic disease. So when you do a PSMA scan or a C11 choline or acetate scan, very often we'll be able to detect metastases that were not detected on conventional scans, CT scan or bone scan. And that can be very informative in terms of moving forward with sort of this aggressive multimodal approach for oligometastatic disease. So bottom line is I use the novel imaging modalities for high-risk disease, as well as for patients who have oligometastatic disease based on conventional imaging. Whether or not these modalities and acting upon them changes outcomes is still yet to be determined. But in the meantime, that's my approach to novel imaging modalities in the initial staging of prostate cancer.